Hello everyone and welcome back to our MRCP Part 2 High Yield Revision Series. I am Dr. Waladin and here we go now.
The content presented in this video is intended solely for educational and revision purposes. This video does not constitute medical advice. The information provided should not be used as a basis for diagnosing, treating, or managing any individual patient or medical condition. The presenter and the production team accept no liability for any outcomes arising from the application of this content in a clinical setting.
Today, we are going to work through one of the most clinically important questions in rheumatology, and one that appears again and again in the MRCP examination. The question is this: you have a 45-year-old man who presents with sudden, severe pain in his first metatarsophalangeal joint, that is, the big toe joint. The joint is red, hot, and exquisitely tender. Now, here's the critical part. This man has chronic kidney disease, and he's taking Warfarin. The question is simple: what is the safest and most appropriate treatment? By the end of this lecture, you will know exactly how to answer that, not just for the exam, but for every patient like this you will ever see in clinical practice. Before we look at individual drugs, let us anchor ourselves to the core concept. Managing an acute gout flare is not simply a matter of reaching for the first anti-inflammatory on the shelf. It is always guided by three key principles. Principle 1. Rapid symptom control. The patient is in pain. Our job is to bring that inflammation down quickly. Principle 2. Patient comorbidities. Does the patient have kidney disease, heart failure? Are they pregnant? These factors completely change which drug is safe. Principle 3. Drug contraindications. What other medications is the patient on? What organ systems are at risk? Remember this phrase: in gout, the correct treatment is not just about the drug, it's about choosing the safest option for the patient in front of you. Our first drug class is the non-steroidal anti-inflammatory drugs, the NSAIDs. In an otherwise healthy patient with no significant comorbidities, NSAIDs are your first-line choice. The commonly used agents include naproxen, indomethacin, and ibuprofen. However, and I need you to pause here, there are situations where NSAIDs become dangerous. You must avoid NSAIDs in three critical situations. First, in renal impairment. NSAIDs reduce prostaglandin-mediated renal perfusion and can cause acute deterioration in kidney function. Second, in patients with a gastrointestinal bleeding risk. Third, in patients taking anticoagulants, such as Warfarin, because of the increased bleeding risk. Key exam point: if a patient has chronic kidney disease, do not use NSAIDs. Full stop. In our scenario, the patient already has chronic kidney disease and is on Warfarin, so NSAIDs are immediately ruled out. Our next option is colchicine. Colchicine steps in precisely when NSAIDs are contraindicated. It works by inhibiting neutrophil migration, essentially stopping the inflammatory cascade before it spirals. Let's talk about dosing because this is frequently tested. You give 1.2 milligrams initially, followed by 0.6 milligrams 1 hour later, and then 0.6 milligrams twice daily thereafter. Now, who is colchicine appropriate for? It's safe to use in patients taking Warfarin, and it's appropriate in mild to moderate kidney disease. But here's the important caveat: avoid colchicine in severe kidney disease. Because colchicine is renally cleared, its accumulation in severe renal impairment creates a real risk of toxicity. Key exam point: colchicine is safer than NSAIDs in anticoagulated patients. If your patient is on Warfarin and has mild to moderate KD, colchicine is your friend. Now we reach the third option: glucocorticoids, the steroids. Steroids are not just a fallback. In the right patient, they're the preferred choice. When are they preferred? In patients with chronic kidney disease, any stage, in pregnancy, and in patients who cannot tolerate either NSAIDs or colchicine. The typical regimen is prednisolone 40 milligrams daily, followed by a gradual taper over approximately 10 days. As with all steroids, there are cautions. Use with care in patients with diabetes mellitus because steroids will raise blood glucose, and in patients with hypertension. Key exam point. Steroids are the safest option in renal impairment. They don't depend on renal clearance the way colchicine does. They don't damage the kidneys the way NSAIDs do. When in doubt in a patient with significant renal disease, steroids are your safest bet. The fourth and final drug category is the interleukin-1 antagonists. These are targeted biologic agents that block the IL-1 pathway, the very pathway that drives the acute inflammatory storm in gout. The examples you need to know are anakinra and canakinumab. Now, I want to be very clear about this. These drugs are used only in refractory cases. That means when all standard therapies have failed or are contraindicated. Key exam point. IL-1 antagonists, anakinra and canakinumab, are reserved for refractory cases only. If an exam question offers you anakinra as a first-choice answer, think again. Now, let's bring everything together into a clear clinical decision pathway. When you see an acute gout flare, ask yourself the following questions in this exact order. Question 1. Are there any contraindications? If the answer is no, if the patient is otherwise healthy, start with NSAIDs. That's your first choice. Question 2. Is there renal impairment or is the patient on anticoagulant? If yes, use colchicine or steroids. Question 3. Is the CKD severe? If yes, colchicine is now also off the table. Choose steroids. Question 4. Has the patient already tried and failed or is intolerant to all standard therapies? Only then consider IL-1 inhibition. This pathway is your mental flowchart. Follow it every single time. And for our original patient, CKD plus warfarin, colchicine is acceptable if the CKD is mild to moderate, but steroids remain the overall safest choice. And now our rapid recap. Point 1. Acute gout treatment is always guided by comorbidity. Never prescribe on autopilot. Point 2. Avoid NSAIDs in CKD. This is the single most tested point. Write it down, memorize it, own it. Point 3. Colchicine is safe in mild to moderate renal impairment, but avoid it in severe kidney disease. Point 4. Steroids are your preferred choice in renal impairment and in pregnancy. Point 5. IL-1 antagonists, IL-1A and canakinumab, are reserved for refractory cases only. Medicine is always about context, the right drug for the right patient at the right time. Thank you for studying with me today. This is Dr. Eldin Ahmed, wishing you confidence in your exams and clarity in your clinical practice. Good luck. You've got this.
If you like this series, please hit the like button and subscribe for videos like this. Bye for now.